Medicare is paying them less for the exact same thing. And really, it's dramatically less than it was previously. It's costs them more to have nursing staff, costs them more to have front desk staff. And so we don't have the margin that we used to. What then? And so consolidation is an obvious answer of what then.
Well, Anna, thank you. You and I seem to run in the same circles. We see each other at a lot of the same conferences. I know that you're very much involved in healthcare. I know you're a partner at JTaylor. I know you consult in the healthcare space. How did you get involved in healthcare 20 plus years ago?
Yes. Accidentally is probably the honest answer. I originally went to Arthur Andersen to be a part of their strategy, finance, and economic consulting group. And when I did so, got involved in some disputes, and they happened to be in healthcare pretty quickly in my career. And so then with the demise of Arthur Andersen, I went to Ernst & Young and worked in their national healthcare group. And so I think the reason why I stayed in it is because it's complex. I don't think we have figured out how to fix healthcare yet. And so that intrigues me still today. But further than that, it does allow me to utilize data analytics and finance in a way that I think actually impacts people's lives. And so there's a warm, fuzzy component that's really interesting to me as well.
So tell me, how do you use data analytics to help advise healthcare clients on M&A deals?
Oh gosh, every moment. So our group specializes in being in the weeds. We're in the weeds of people's financials, and we're also in the weeds of their billing data. And so one of our unique expertise is understanding how a bill gets out the door and when it gets paid, how it gets recorded, and then determining whether we were paid appropriately. And so that expertise in healthcare, in finance and accounting is sort of unique to be able to cross those different spheres.
I think we have some similar types of clients, but why don't you explain what the types of clients that you represent and the things that you do for them?
Yeah, sure. My clients right now are very varied, is what I would say. So I have some clients that are 1 or 2 man groups, physician groups that are specialists who are working hard to stay in independent medicine. We have large 400, 500,000 person physician groups that we work for. We work for hospitals as they are acquiring hospitals, surgery centers, physician groups. And then we also work for financial buyers and their representatives as well. So I work for investment banks. I work some for private equity, other roll-ups, and then always work with my friends in the legal community as they are putting together deals and also dealing with disputes that occurred on deals.
When you work for group practices, whether they be small or even larger group practices, do you work with those practices, before an acquisition is on the horizon? Do you help try to get them ready for an acquisition, or really just to increase their revenue? What types of things can you do for those types of practices?
Well, I definitely have a couple of small and really large groups right now who are trying to figure out how to stay independent. And so for them, we're helping them run a practice well. And what that means is we're helping them make sure that their commercial managed care rates are good, that their rev cycle is well buttoned up, that they're getting paid for their services well, but that also that they're using their expenses wisely and able to recruit and retain providers as they grow and also do succession planning. So that's one area where we specialize. And really that's the same, but with a different outcome than the work that I do when we are trying to prepare somebody for sale. And when we're trying to prepare someone for sale, we're actually doing the same things. And that is make sure revenue is as high as it can be, that we're getting all of it in the door, that we should be able to collect from an allowable perspective, and that the expenses are being efficiently used. And that we have a good feel towards what we're going to pay our physicians, our providers, and why, and that aligns with what we're trying to drive from a value perspective. So it's really can be the same, even if my clients are trying to do something very different.
Gotcha. So, well, let's talk about the market then for healthcare acquisitions. Um, Over the past several years since COVID, there's been some years where M&A deals were blowing and going, and there's been other years where they've slowed down. Where were we in 2025, and what do you expect throughout 2026 in terms of the volume of the healthcare acquisitions and mergers?
Hmm. Well, I think one of the best people to talk to on that is an investment banker, because they're the ones seeing deals before they occur. And I was just on the phone with one earlier today talking about a new deal, and they were saying that it has been choppy the past couple of years, meaning not full volume for the past couple of years, and now they're feeling very full. I think that's an interesting statement coming from an investment banker. And
Feeling
so
very full, meaning, okay, maybe we can slow down a little bit. Maybe we can be a little bit more picky. Is that what being full means?
I don't think most investment bankers prefer to do that. I think what they mean is that they're happy with the amount of volume and it being very high volume right now. So we're seeing a lot of people um, test out the market again in 26. 25 was a slow start and a pretty strong ending, and I think we are seeing a continuation of the strong ending. Um, I think we've reset some of the expectations of what the multiples should be. And yes, the interest rates are still a little high, but I think everyone has kind of recalibrated a little bit to them. And there's still enough dry powder or cash on the sidelines that are driving deals, and still a need for consolidation due to macro healthcare economic issues. And so I think we're seeing still a pretty good market here for
Okay,
deals.
so if we got a healthy volume, are they the same types of deals? Um, I ask because
Mhm.
I've represented folks in the past several years, physician practices that have uh, uh, entered into arrangements with hospitals under a foundation
Mhm.
model arrangement. But I've also represented folks that are part of a roll up of with a private equity roll up. And my
Mhm.
sense is the private equity side is outpacing the hospital side. But I don't see the volume of deals or all those types of deals that you see.
Mhm.
Is there a difference in the types of deal volume or the types of deals that we're seeing?
Great question. I am seeing um I do see a little bit of a slowdown with hospital deals right now, just a little bit. And I think it's because the hospitals are feeling the economic issues that occur in a physician practice that are maybe not as attractive. And the hospitals are seeing some of the same issues that the physician groups are from the perspective of uh, how they fund physician compensation. Where we are seeing a ton of volume right now is in surgery centers. And I don't think hospitals have slowed down, and I don't think the major aggregators and the big roll-ups of surgery centers have slowed down at all. In fact, I think it's just accelerating right now, and I think it will for a while. Um, Particularly for the hospitals who have played in that space. I think it's well received by almost all the parties, the ASC volumes that we're seeing. And I think that will continue to be the case because it is a lower cost of care. Um, I think patients prefer it, insurance companies prefer it, actually, physicians prefer it. So most of the stakeholders are aligned on that deal. And so I continue to believe that that's going to have a good, clean runway on it for the future. Um, Private equity, I do think, is getting a little pickier on some physician deals. And I think that's a good signal, I think, for healthcare in total. in 21, there were deals occurring because deals were occurring. And at times it felt like that was the reason for the deal, was because maybe we should do a deal as opposed to a well thought through investment thesis. And so I think private equity's gotten a little choosier on some of the physician deals that I'm seeing.
Do you think that private equity's been in the news a lot lately, and not
Mhm.
always for the best of reasons. And as a result, legislatures, not just in Texas but other states,
Mhm.
are scrutinizing private equity deals more and more in healthcare. Some to the degree of requiring notice prior to closing some of these deals. Do you see that as a headwind to these private equity deals, and are is that going to continue? I mean, I know you don't have a crystal ball, but in terms of the people that are putting the deals together, is this regulatory scrutiny going to slow them down or make them be more picky, or um, I guess more deliberate in the types of practices they seek to acquire?
Yes, we have experienced that. Um, some of the states that have the most amount of restriction, California comes to mind quite often. Um, if you're trying to sell a practice right now in California, I think you get less bites and less competition on the deal than other states. And we've actually seen some buyers wave off um, bidding from an RFP perspective on deals. So yes, I do think that's an impact. I don't think it's the only piece. I think that's probably a broader picture of the entire regulatory environment in certain states. It's not only the private equity, but it's the corporate practice of medicine, and it's the licensing, and it's some of the tax pieces. They tend to run together, is I guess what I would say. And so, yes, I do think those have maybe seen a little bit of a downturn in certain states, and we do see that affect things.
There's been some high profile FTC challenges to roll ups
Mhm.
who they'll buy a lot of practices in a region and then increase prices. And of course, the FTC frowns upon that as being anti-competitive. I'm wondering if those types of not just legislative challenges, but maybe litigation or public FTC opposition to those types of deals are also causing roll ups or private equity to be more choosy in the markets they choose to enter.
Um, Maybe so. I don't think I've seen as much cooling on that effect that I would assume. And I think it has to do with again, if you think through the economics right now of physicians, um, Medicare is paying them less for the exact same thing. And really, it's dramatically less than it was previously. It's cost them more to have nursing staff, cost them more to have front desk staff. And so we don't have the margin that we used to. And so what then? And so consolidation is an obvious answer of what then? And so private equity or not, whether it's private equity, a non-private equity backed roll up, which those exist right now, working for a number of those are interesting animals. Hospitals, I think physicians are looking for a safe place to practice medicine. And I haven't seen as much headwind on that as you might guess. And I don't know that we will, because I'm not sure what the alternative is for a group that's not able to make the math work anymore.
So your experience, and I echo this. I see physicians, not just physicians, but I guess all the downstream providers who have some component of Medicare as in part of their payer mix. They are getting less in terms of reimbursement. Costs
Mhm.
to provide care are increasing for them, both in terms of the technology costs, the physical facility costs, the personnel costs, and it's driving providers to look for different forms of reimbursement. Maybe not so
Correct.
much rely on Medicare. A lot of my clients are looking toward more cash pay type clients,
Yes.
and as a
Mhm.
result moving toward more I guess, popular, trendy types of medical services, whether it be medical weight loss or testosterone replacement or
Mhm.
other things that are predominantly cash pay.
Yes.
Yes. So what alternatives do you see, the practices that you work with? Where are they looking to make a change in their payer mix?
Gosh, you noted some of the high points there. The GLP-1s are a big component. Unfortunately, I think we see a number of primary care physicians leaving primary care for more what I would call cosmetic or med spa, consumer driven healthcare that either has a GLP component or a hormone component, or some sort of a nutrition component to it. So I do think that we're losing primary care to that world. And we see a lot of deals in the med spa space still today. That is still a hot sector
I
for
do a
the
lot of
deals.
med spa deals. That's right. Yeah, I also
Um,
see. Tell me if you have this experience. I see folks that
mhm.
are kind of foregoing the traditional physician model, and they will do like telehealth services where they'll do a good faith exam. They'll have a nurse practitioner do a good faith exam and write the orders, and then deliver the prescriptions through maybe a compounded pharmacy, or that deliver the drugs directly to the patient. And so they kind of forego the entire um, traditional physician model where patients come into an office and are seen by staff and whatnot. It's all online now. I'm wondering
Yes.
if that is in response to just the continued downward pressure on reimbursement rates and increases in costs.
I definitely think that, and I think the other piece that we haven't talked about overtly yet is the required administrative burden for commercial insurance. There's denials are going up dramatically, pre-auths, pre-certs. So I think we're seeing physicians and providers and investors get very creative with regards to what their business model looks like and what piece of the healthcare spectrum they can practice in while avoiding some of these issues. Concierge medicine, we do see a good bit. And again, that's a net negative out of the primary care base of available physicians. And when we talk to them about it, they're saying I can't do this speed. I will get burned out, or I don't like the way practicing medicine looks and feels today. And so, yes, it's Medicare, but it's also the commercial payers as well that are pushing this.
And I guess surgeons, for example, that need a hospital, a facility, or an
Mhm.
ASC. And I guess maybe that's why you see ASCs being,
Yes.
continue to be popular, is that you can provide those types of services maybe with less overhead than a traditional hospital setting.
Very much. And for the surgeon, it allows them to have a new income stream. That would be a facility fee. For the insurance company, it decreases the cost of care. For the patient, it improves the experience most of the time. They get to park closer, not deal with walking through hospital lobbies with sick people. And the surgeon likes it also because they get to call the shots in the OR better than they did previously, and the turn times are better. So I really think ASCs still have a ton of runway in front of them. So most people are now getting hips and knees out in ASCs as opposed to hospitals, and I think the outcomes on those have been pretty great. Very little downside unless you're a hospital that previously relied upon that revenue.
You had said earlier that you thought some hospital deals might be slowing down some. In my experience, I'm seeing hospital deals change a little bit too. Instead of acquiring a physician practice under the foundation model, they are doing more of a partnership or a joint
Mhm.
venture model. It's not really a foundation model, but there is elements to it in that the hospital will provide some management services, but it's not acquiring the assets of physician group. It's just partnering in a joint venture agreement and then providing those services, and all the reimbursement is going through the hospitals, who may get higher reimbursements rates than the physicians could by themselves.
Yeah, I think those are so interesting and should be the future. I think they better align everyone's best interests, I think, for the most part, as compared to a true employment deal. Now, I think a physician may feel a little less safe in one of those foundation or joint venture deals because they're not taking all their risk off the table, right? They still have some element of economic risk. But again, as a consumer and also as an owner of a firm where we pay a large chunk of our revenue towards insurance premiums on behalf of our staff, I sure would love to see us use that money efficiently. And so I think there's interesting structures ahead on that, and ones that I would prefer.
Those joint ventures are interesting, and I think you're right. I mean, there are certainly some advantages to those for physician groups. There's also some disadvantages. The
Yeah.
hospitals in this joint venture, they'll create a physician, a network, but they want their expenses taken off the top out of all the reimbursements before anything's pushed down to the providers. And so, if there's a clawback from the insurance company or Medicare, it's coming out of the pocket of the physicians after the
Mhm.
hospital's already taken their expenses. So the hospital is in a lot of ways immune from the clawbacks because they've already gotten their expenses paid, and the joint venture agreements require all overpayments to be refunded by the providers themselves. So I guess my point is to say that these are interesting arrangements, but I'm
Mhm.
not sure the mentality of some of the hospitals has really caught up to market realities, that it's a good deal for both parties. But if the hospitals are going to continue to push the risk completely to the physicians, then they may not be as popular as they otherwise could be.
Fully. And I think what you're highlighting is that a deal like this, um, I like them because of the flexibility, but the flexibility inherently results in complexity, right? And we're not talking about one way to do a deal. We're talking about thousands of different ways to do a deal when we're in this realm, because it's not just an employment deal, or we're not just purchasing and then billing under the new tax ID. So yes, I would say that the financial modeling and the legal work around something like that should be a little more detailed
Yeah, it's a lot more
because of
detailed.
exactly what you address.
Yeah, and it's about like both all parties want to manage risk and mitigate their risk, and
Mhm.
so the hospitals come into it with maybe a pre-existing kind of historical perspective that, hey, we're doing the physicians a favor by partnering with them, but in reality it cuts both ways. Physicians are providing a level of care to patients that under hospital run type physician groups, maybe they didn't have the same level of success. And so
Right.
joint ventures allow the physicians, and not just the care they're providing, but also the efficiencies of the management of care that maybe hospitals have not really been able to appreciate.
I would hope that if well done, a deal like that would result in some efficiency in lots of different areas, not just in the care provided, but um, often when we see physician or hospital owned physician groups, the overhead within those groups are strong. And I wonder if we can't get to a middle ground there on maybe not providing the latest and greatest of every software package that exists, and instead, um, I I don't know. I hope that they can be run more efficiently than a hospital-owned physician practice.
there's a level of bureaucracy in a hospital that's understandable,
Mhm.
given the regulatory complexities of practicing medicine and healthcare
Yes.
today. But it's also a bureaucracy that does not lend itself to being to a hospital being agile and being able to adapt to market forces quickly. And private physicians or physician groups bring that level of experience or bring that expertise to these deals of having to adapt and having face time with patients and dealing with insurance companies and reimbursements that I think physicians can provide a level of expertise that hospitals have not otherwise had. um, I, I want to pick your brain about these physician groups. You had mentioned that you represent physician groups, some large, some small, some pre-acquisition, some in acquisitions. I get asked a lot by my clients what they need to do to make themselves more sale ready or more attractive to investment bankers or potential private equity or just future acquisitions. What I mean, I'm sure you get that question a lot too. What types of things do you encourage your clients to do to make themselves more attractive to potential sales, either in the near term or even down the road?
Yeah. Um, a couple different things. Size matters in this area. So I would say having a good pipeline of providers of in the next several years, these are the number of providers that we're going to be hiring. These are the next geographies of where we're going to put the next clinic or the next surgery center or the next imaging center or whatever it is that we're talking about. So having a clear view of how it is that we're going to grow, I think is helpful. Any way that you can articulate this is our footprint within the market that we're in, and this is how we are addressing shortcomings and how we're acquiring patients. I think it's always good to have your house in order. I would put managed care rates at the top, one of the top items of something that you should be working on, and admittedly, it is one of the slogs within healthcare that is least fun is addressing managed care rates. But if you haven't looked at your managed care rates lately, I'd say you're a little behind.
I guess
Um,
that is where size matters also. The larger the
it
group,
does.
maybe the more leverage you have to negotiate more favorable rates.
It does, and it's the larger the group, but really it has to do with geographic density and the market share for where patients are coming from.
Mm.
So even if you're a DFW only group, if you are 50% of the market share in DFW, you can have a say in what occurs. If you are a really large group but are scattered across 3 states, that doesn't really result in any sort of geographic density or leverage with regards to payers. So it's interesting as far as how that works. The size isn't 100% of everything, but it is absolutely related. But then, in addition to managed care rates, I'd say having your books in order. Anyone doing a sophisticated deal is going to be very much in the weeds on all your entries in your QuickBooks or in whatever general ledger you're in. And then your agreements with providers as far as how you're paying them need to be fairly well buttoned up and again need to be oriented to what you are driving at. Um, I eh, Lastly, I'd just say key key places that you get volume, that you get revenue, that you get referrals, to the extent that you can memorialize what those are, preferably in some sort of a legal agreement of some sort of working together or medical directorship or something that allows it to be just a smidge more sticky. I think to the extent we can pass something across the table to a buyer and say, all of our volume occurs at XYZ hospital, and we have a call arrangement with them and a medical directorship agreement with them, and they've helped us recruit before. I think some of that helps round out the strategy of what we're trying to articulate to a buyer.
You talked about you're getting your regulatory house in order and your financial house in order. I had an attorney say to me a couple of weeks ago, he typically represents buyers, private
Mhm.
equity buyers, and he said to me, one of my goals is to find all the problems I can, big or small, in a
Yes.
potential seller so that we can drive the price down. We drive
Correct.
it down through either contingencies, putting money aside,
Escrow sweeps.
escrowing, or encouraging self-disclosure if we see issues, stark issues, or anti-kickback issues. And this is so common in smaller practices because even if they are doing things right, they often are not documenting things right, and so they can't prove they are doing things correctly. But oftentimes too, maybe they're not even doing things exactly the way they should, and there's issues with some physician compensation agreements. Or maybe they're compensating physicians based on designated health services that the
Mhm.
physician is ordering but not performing themselves. Those are stark issues, and buyers counsel look for those issues so that they can drive the price down. So to get your regulatory house in order, those are the types of things we need to button up before they start scrutinizing your balance sheet and your agreement.
Yeah, I would advise anyone who's really thinking about doing a transaction to do a dry run of what we think buy side's going to say about our deal. And so we're engaged in that quite often. We're engaged by investment bankers as they consider taking a business to market, and we do sell side due diligence to find where the holes are in the financials. Um, but the same should be occurring from a legal perspective. Do we actually have all of our legal agreements signed up to date in order? And how will we explain our ancillaries? Um, I,
That would be great. That assumes that you have clients that think ahead. Most of the time, my clients call me and say, "Hey, we're closing on Friday for this sale. Will you look at the documents?" So they've
mhm.
already blown past the letter of intent. They've blown past due diligence. I'm just getting involved after everything's already baked in, and it becomes an even bigger challenge. At that point, there's not much you can do. So the message to those listening today is if you want to sell your practice, don't call your lawyer the day before you close. Think about this months before.
You need to have your team of advisors involved maybe 6 months before close, maybe more than that. Um, and again, we can demonstrate and we can show return on investment or ROI on our work ahead of time because we can articulate, oh no, that data set was wrong. You shouldn't be using that. Here's the one. Or because this negotiation that you reference on buyer's counsel of trying to knock the price down absolutely occurs on the financial side. So even if you have an LOI, it's a non-binding LOI, and it says price is going to be X million or X multiple times EBITDA, we see those retraded quite often. And I can maybe count on two hands how many times the number's gone up. It goes down most of the time. So if we can avoid that negotiation going down, it's worth our fees often, particularly if you're talking about a deal that's based off of multiples. That ROI normally works. If we can argue, oh no, you didn't account for the fact that Dr. So and so was out due to maternity leave, or Dr. So and so was out due to a heart condition, or whatever the issue might be, or we had a rev cycle issue this year, or we can articulate lots of different things that explain why the numbers aren't what they should have been. And most of the time we can get credit for it. Not always, but at least it's an argument on the other side. Otherwise, it's a very asymmetrical negotiation. And I wonder at times if people know that they're in an asymmetrical negotiation. Uh,
I'm not sure some of my clients appreciate they're in a negotiation at all. But
right.
they think that, hey, they want my practice, and boy, that's a lot of money, and in reality, it's not as much money as it could have been
Right.
had they gotten their ducks in a row ahead of time.
Right. So at the risk of sounding self-serving as though I'm looking for more fees, I really would not advise even a small practice to go into a deal without a team of advisors, and truly a team. I would say legal and finance needs to be sitting at the table because the other side will have that. They will.
especially private equity, they're going to have that. They're going to, I mean, they will have already done some amount of due diligence on your practice, but maybe even before they approach the seller. Or, you know, as they're looking for potential acquisitions, they already know what they're looking for. They already know what they think the market is. And so if you don't have counsel, legal counsel or financial counsel, then you're really, you know, got one arm tied behind your back.
Fully. And I would even go so far as to say, if you talk to most of my private equity clients that I work for, they'd say they would prefer to do a deal that has advisors on both sides as well, because they want the deal to close and be done efficiently. And often business owners, well, they might underestimate how much effort goes into closing a deal and how much that's going to take them offline from their core business, but also may not be their expertise, right? Most of the physicians I work with are not
Well, it certainly
CPAs,
is
and
not
most,
their expertise, and they get
yeah,
frustrated because they look at all this list of due diligence requests. They don't
yep,
have these documents. They don't know what half the documents are, and they get frustrated. And ultimately, it's either the deal doesn't close or it closes for a lot less than it otherwise would.
exactly.
Um, you know, I can help my clients on the legal side, but I can't help them on the financial side. That's where you come in. How do folks get in touch with you if they need advice on getting their practice sale ready, or maybe they already have some inquiries about buying their practice and they need to start putting this team into place? How do people contact you?
Yeah, look me up on jtaylor.com. It's JTAYLOR.com. And yeah, my email's out there, my telephone number's out there. And I, I mean, one of the more rewarding things that I do is speak to physician owners, entrepreneurs, um, even not non-physician owners, nurse practitioners, midwives, about what it is that they've built and what they want for the future of that organization. I mean, what an honor to get to work with people who have spent their lives building something. So um, that's a joyful moment when I get a call from somebody who's looking for some help.
It's much better than the call that I usually get that, hey, we're closing on Friday, can you help?
Right, right,
So you're
right.
lucky if you get the other calls more often. Uh,
Yeah,
Anna, thank you. I always appreciate getting to talk with you and your insights. Anna Brewer at JTaylor. More information, I'll put it in the description of the video. And if you need help, I encourage you to reach out to Anna and the entire JTaylor team. Thank you. Appreciate your time today. Thank you.